Good evening once again, and thank you for everybody who has joined and is still joining. We are expecting more people to join, but in the interest of time, I think we're going to continue. My name is Dini Mawela. I'm currently the acting dean in the School of Dentistry, and I bring you SMU greetings. This webinar today is part of a series of webinars that are being organized through the Research Directorate at SMU. And this one in particular today, we want to thank the Schools of Medicine, Dr. Talekan, and the Schools of Dentistry, Dr. Mpongose at SMU, who are going to be presenting the case and the discussion today. But it's also in collaboration with our partner, RARE 360, and we are grateful for this partnership. Just a bit of background, following the celebration of the Rare Disease Day on the 29th of February at SMU, and most of you will remember the celebration we had, we decided that we would be running this series of webinars to achieve a few things. And some of that is to create awareness around rare diseases, but also to create a safe academic space for dialogue amongst ourselves as we try and co-create solutions around early identification of patients or people living with rare disease. We hope eventually that we will improve the clinical care that we give to these patients. We hope to improve our ability to diagnose these conditions early and to provide adequate and quality treatment. And hopefully in the end, we will have research that comes out of this project that will inform Africa, that will inform the world about rare diseases. So we're very excited to have you here on the platform. And as I said, we are going to have two clinicians, one from the School of Dentistry and one from the School of Medicine, who are going to be presenting. And I'm going to welcome Dr. Sandile Mpongose, who will be doing the case presentation. He will be followed by Dr. Talekan from Department of Internal Medicine, who will then be looking at diagnostics and other discussions around the cases. So I'm going to hand over to you, Dr. Mpongose, to go on with the case presentation. Welcome, everyone.
Thank you, Prof. Mawela, and thank you to the Prof. Saheri and colleagues who extended the invites to the School of Dentistry and myself. I'm really honored to have this opportunity and excited to share the case. As been said, I'm Sandile Mpongose at the School of Dentistry at SMU. I'm a prosthodontist and a senior lecturer in the Department of Prosthodontics. So I would like to present, by way of introduction, two patients that have been seen in our department. And I'd like to acknowledge the registrars in our department who are currently managing these cases, Drs. Gwala and Mafereka. We have the first patient, a 31-year-old female. That would be the top image, and the bottom image would be a 26-year-old male. The 21-year-old female is an LLB student who is, well, at the time was an LLB student and is now a doing her articles. She's an only child. The only major issues she presented with other than her intraoral condition was amenorrhea and scoliosis. The male patient, who's a 26-year-old student, has one sibling and is the only person in his family who has presented with this dental problem. Other than that, there's not much that is contributory in both their histories. The main complaint, the first patient came with a complaint saying, "I want to smile." The second patient had the main complaint of, I can't eat properly. So upon oral examination, the major thing that one could really establish is that we can observe patients that are partially dentate with some sort of gingival enlargement, and we needed to investigate as to what is happening because this was a bit abnormal. Upon intraoral examination, what we can observe with the first patient is that we have an individual who exhibits quite thin enamel. There's delayed tooth eruption. As we all know, by the age of 31, all of these teeth should have been erupted. If we are really going to not be too concerned if it was just one or two teeth that are impacted, as that is normal. However, we can see there are multiple teeth that are unerupted. There are intrapulpal calcifications. There's gingival hyperplasia. The teeth appear to be microdonts. And also we can observe on the radiograph some dilacerations, hyperplastic follicles, and a view of some torridont or torridontism on the with the dentition. And obviously the retained primary teeth. With the second patient, we also observe a similar image where there is thin enamel, there's delayed tooth eruption, again intrapulpal calcifications. But what is different with this patient, we can observe that there are molars without any cuspal features at all. They look, in fact, as if they had been amputated, but obviously this is not the case. So this is quite an abnormal situation that we are observing here. Now, when looking at this, one had to go through certain aspects to kind of think what exactly is happening here. And there are quite a few syndromes that could be linked to this, okay? Which range from anhydrotic ectodermal dysplasia, craniocrital dystosis, Gardner syndrome, Gordon-Sedana syndrome, Eunice-Verron syndrome, and if it's non-syndromic, this could be just idiopathic. Now, these syndromes generally have multiple impacted teeth, and that's how this usually present. Now, in the case of, if we go to craniocrital dysplasia, the patient usually exhibit high arched palate and prolonged retention of the deciduous teeth, leading to subsequent delay in eruption of the deciduous teeth. Now, through both the intraoral features that were present in these cases, there are no abnormalities of the skull, shoulder girdle, and along with multiple supernumerary impacted teeth. All of this was kind of absent in these cases. So in a way, it starts ruling out the syndrome itself. There's also sometimes narrow sloping of the shoulders, again, which was absent, and delayed fusion of the cranial sutures and other dental abnormalities. Again, this is not something that is present in both cases. And when we look at Gardner syndrome, which also presents with multiple impacted teeth, this was ruled out as the associated signs, like multiple epidermoid cysts and other lesions, were absent. When looking at Gordon-Sedana syndrome, we can see that that represents short hands and feet, bones with short and straight collarbone, along with multiple impacted teeth. Again, this was not present in this case. Looking at the last syndrome, Eunice-Verron syndrome, where agenesis or hypoplasia of the clavicle, severe micrognathia, and digital anomalies. So again, this is something that was absent in this case. So it was very clear that the syndromes that we generally associate with this type of oral presentation was not necessarily it. So what we then needed to look at is what else could be out there. And what we came across, which I will allow Dr. Talikan to expand more on, is there's a potential that this would be what we could call enamel renal syndrome. This was first reported or described by McGibbon in 1972, where one of brothers, it was two brothers, and one had passed away due to renal failure, but had presented with this intraoral image. It's said to be a rare autosomal recessive disorder. It presents with nephrocalcinosis. Intraorally, what you would see is amelogenesis imperfecta, the hypoplastic type, impaired tooth eruption, microdontia, intrapulpal calcification, and gingival fibromatosis. So this picture is starting to look similar to what we have in the two cases that are before us, but there are other diagnostics elements that need to go into this for us to conclude if that's the case. Other aspects that may present themselves with ERS, when we looking at a review by Moray in 2021, where they had a cohort of 25 patients from 16 different families, that it could be hereditary because consanguinity was present in their cases that they saw in 26% of those cases. And there was a family history in about 43% of those cases. There is, however, no relation to gender, and also there's no association with nationality or geographic location. Now, in some cases, hearing loss has also been present, and hypertrichosis, but these were all non-specific findings. So I think I've mapped out what both cases are and what the diagnoses could have been, but what we sit with before us does not fit into any of the diagnoses that syndromes that this could present with. So this is when we then asked for further investigations, and it's at this point I'm going to ask Dr. Talikan to take over.
Thank you, Dr. Mpongose, for the case. Are you not going to take questions? No. At the end. All right. We'll take questions on the case at the end. Please write your questions down. I want to acknowledge Ray 360 and Nadia in her absence, but I also saw that Dora Mugambi is online, and we want to welcome our sister from Canada, and thanks for joining. And once more, thanks everybody for joining. I don't know if Wesley is sorted. Wesley, let's give it one more try.
Mpongose, thank you so much for that presentation. It looks very much like very possibly an autosomal recessive disease. I'm going to talk more from the renal aspect, and then focus a bit on the genetics and show what we can do. Can I have the next slide, please? Thank you. So enamel renal syndrome is a very rare disease. It's also an orphan disease in that there are no guidelines or treatment protocols that are available or designated medications. So it's very rare, less than 100 reported worldwide. And the largest case series that we've seen so far has actually been a sub-Saharan case series with 4 cases from Harare, Mpumalanga, and Cape Town, published last year. And as you can see with the PubMed a screenshot that I put in there, there's only 51 publications about this disease worldwide. So it's truly a very rare disease, and very much unstudied, and very little is known about it. Next slide, please. So, as Dr. Mpungose mentioned, it's an autosomal recessive disorder, and it combines two major phenotypes. So amelogenesis imperfecta, which is the dental abnormalities, and then there are renal abnormalities, which include nephrocalcinosis, which is basically calcification of the medulla of the kidneys, as you can see in that CT scan on the top there. Those very white spots just underneath the liver and the spleen are calcifications in the kidney. And these calcifications lead to recurrent infections and microscopic hematuria in the urine. There's also an occasional renal tubular acidosis, type 1, and that will be relevant in when I'm going to talk about a bit later. Next slide, please. So the problem with enamel renal syndrome is that it's heterogeneous, and it depends on the type of mutation or variation in the FAM20A gene. And from what I can understand from the literature, all of them have amelogenesis imperfecta of variable severity, and the renal findings vary. And this is in contrast to just isolated amelogenesis imperfecta, where there's no renal disease and there are lots of genes. I think there's close on 20 genes that have been implicated in it in different studies. In the 2023 study, they looked at those 4 patients, and 100% of them had the FAM20A variant, or A variant, not the same variant though. They were different, in an autosomal recessive pattern. They all had amelogenesis imperfecta, so they all had the dental abnormalities, but only 25% of them had nephrocalcinosis, and 50% had hypocitraturia. Now, citrate is a organic molecule that chelates calcium, and this might be the reason why these patients have the calcifications or nephrocalcinosis in their kidneys, but we're not 100% sure. The literature is not very clear on why the nephrocalcinosis is there, or the renal tubular acidosis. Next slide, please. So focusing just on amelogenesis imperfecta, there are 4 types, of which the one of interest to us is the type 1, where it's autosomal dominant recessive or X-linked. And as mentioned by Dr. Mpungose, it is very variable phenotype. But if you have a look through all of the different types here, the clinical appearance is there's an overall either hyperplastic or hypercalcification generally, with brittle enamel that is what the patients present with. But the inheritance is very variable from X-linked to autosomal dominant, autosomal recessive. And what we'll see just now is the reason for this, why it's so variable. Next slide, please. So the major genes that are known, the first one is FAM20A, and this is the one where there's enamel renal syndrome. And there we get the enamel defects, or the amelogenesis imperfecta, plus the renal manifestations, and it's autosomal recessive. Then there are other genes, but importantly, none of them have renal manifestations, while the enamel defects or the teeth defects are a variation on a theme, I suppose, is the best way of describing it. Next slide, please. So the gene of interest at the moment is FAM20A, which is on chromosome 17, and this regulates the biomineralization of the teeth, so the hardening of the teeth, depositing calcium and phosphate into the teeth. Its exact role in the kidneys itself is not 100% clear, whether it's related to not reabsorbing calcium and phosphate, or if it's causing citrates to be low in the kidneys. We don't know. I suspect that it's just the calcium and the citrate are complexing a lot because there's a lot of calcium that's not being absorbed. And then when the citrate runs out, then it forms the calcium deposits in the kidney. But that's an hypothesis at best, so we're not sure. There are a couple of common mutations. So the stop codon R136X, a 2 base pair deletion causing a frameshift mutation, and then a few splice site mutations. But they're all associated with amelogenesis imperfecta and nephrocalcinosis or enamel renal syndrome. Then Amylyx, which is a gene on the X chromosome. It's a structural protein of enamel, and as I understand it, it builds up the matrix of the enamel that then gets calcified. And if there's a variation here, and it's mostly splice site mutations, then you get abnormal proteins and abnormal development of or abnormal mineralization or enamelification, I suppose is the word, of the teeth. And you can understand why that would not cause renal disease then, because it wouldn't be involved in the matrix of the kidney itself. Next question. Then there's ENAM, which is on chromosome 4. Again, it's a critical matrix protein important in enamel formation. And again, there's splice site mutations. So it's actually interesting to see that there are quite a few splice site mutations in the genes that we are looking at. And again, it explains why it's a recessive a syndrome. Then there are other genes, and there are a lot. And you know, if we need to look at these 2 patients, then we would need to look at all of these genes, unless we know that there is renal disease. Then we can focus on FAM20A. But the defining feature for all of these genes is amelogenesis imperfecta. Next slide, please. So our diagnostic approach for the renal involvement, I'm not going to focus on the dental at all. It's a clinical diagnosis, and we'll start off with a detailed history and examination. And then we will need to look at the urinary dipstick, looking mainly for blood, maybe a bit of protein, but mostly blood. And we'll look at the electrolytes in the urine. We'll also do serum electrolytes. So occasionally there is renal dysfunction with enamel renal disease, but more likely I want to look at the acid-base status of the patient to see if there's a renal tubular acidosis. So this, between the urinary dipstick and the serum electrolytes, that's where I'll get the first hint. Then I'd like to do a 24-hour urine looking at citrate, calcium and phosphate and creatinine, just to get an idea behind the how much calcium is being lost via the kidney and phosphate as well. And I use creatinine as a control, basically. I'd also want to image the kidneys, starting off with a renal sonar, and then doing a CT abdomen, as I showed in the previous slide. But renal sonar will be able to tell us if there's nephrocalcinosis. The renal treatment, I would have to tailor it to each patient. It's mostly supportive, but it depends on how severe the kidney dysfunction is, how often they get bladder urinary infections, how bad the nephrocalcinosis is. So it's mostly supportive, and we would just need to monitor them going forward, as well as educating them. Next slide, please. Now, the slide is a bit complicated, and I apologize, but I will simplify it on the following slide. But basically, what we need to do with these patients is we need to go from the bedside to the research bench and then back again. And what we do is we start out with a clinical suspicion, and then we flesh that out with history and examination, and then we bring in a multidisciplinary team, and we have a discussion, and then we assess. And this, it will start off with dentistry, because most likely patients will present to our dentistry colleagues. Involve the nephrologist, because we need to assess the kidney function and see what if there's any kidney complications with this disorder. We need to involve genetic counselors. This is very important, and I'll spend a bit of time a bit later. Then we'll need to get the geneticists to diagnose the disease, and we'll also focus a bit on the genetic approach. And then the idea is going to be, can we make a diagnosis at the disease or a syndrome level? And I know that enamel renal syndrome is called a syndrome, but in a way it's a disease, because we know it's caused by mutations in the FAM20A gene. Whereas amelogenesis imperfecta is more likely a syndrome, because there will be multiple genes that can be affected here. So if we are sure that this is enamel renal syndrome, then we can go ahead and just look at the FAM20A gene. But it does change our investigation strategy. So if it's a single gene, then we can use Sanger sequencing, which is cheaper, it's accurate, and it's very targeted, but you don't get much information out. And it's relatively labor intensive, and it's quite costly for what you get, and especially if you want to use it for large scale use. If there are multiple genes, next generation sequencing is a better option. There's broad coverage, it's cost effective, and it's actually faster because there are pipelines they've already been set up all over. Thank you. And this mind map, basically, it shows the multidisciplinary team making the clinical assessment, and we have to make the decision. Are we either going to go left to the amelogenesis imperfecta, where there's multiple genes, then we'll do next generation sequencing, or we're going to do enamel renal syndrome, where it's a single gene and we can just do Sanger sequencing. Next slide, please. So this is kind of what we can expect, and it's very basically put here. So with Sanger sequencing, it's, as I've said, there's limited information, one gene, it's time intensive and it's cheap. And here what you see is there's one variation where there's a adenosine, that's the green electrophoregram that is raised there on the far left. In the middle, there's an AG, that's heterozygote, and then on the right, there is a homozygous G. So that's one variant in one spot of the genome. Very limited information, but very clear. Then if we look at next generation sequencing, it's massive information, and you can do whole genome versus whole exome, which is a bit cheaper. As I mentioned, it's quicker because pipelines exist, but it's a bit more expensive. But the outcome, if you look at the those two blocks on the top there, the first one is from a lupus patient of African ancestry, and the second patient is of a European patient with nephronoptosis. So what I want to point out is, first of all, there are it doesn't present very well, but there are 93% of the variants are novel in the person who has lupus and is of African origin, whereas only 6.1% in the European person with a monogenetic disease. So that shows you that's the bias that's introduced into our into the worldwide data with regards to genotyping. Then if you look at the coding consequences, basically the yellow and green circles on the right. The yellow is missense variants, and the green are synonymous variants. And what you see in patients with lupus, they tend to have a lot more missense variations compared to somebody who's got a monogenic disorder, where there's a lot more synonymous mutations. So the point is that the Sanger sequencing, there's only one variant that you're going to be seeing, whereas with the next-gen sequencing, you're looking at 70 to 100,000 variations, and you start to see different pictures for different diseases, which I think is very, very interesting. Next slide, please. So going back to the bedside, what do we want for our patients? So Sanger sequencing is simpler, it's easier to explain, and you've got one gene, one exon with fewer variants. It's simple, it's easy to explain, and it's easy to explain the concept to the patient. Next generation sequencing is complex, it's difficult to explain fully, and you've got many novel variants that are, and there are thousands of them. It's so difficult to understand it and the complexity there. And you know, it's really nice for us as researchers to just get all this data, and you can do lots of analysis, but to bring it back to the patient is also very, very difficult. So we need to be careful when we think about when we do these tests. Next slide, please. So the types of outcomes, and we need to figure out what we want. So what we want in the clinical setting versus what we want in the research setting are quite different. But in the clinical setting, we want definite answers that are simple, easy to explain, and we want lots of answers, but no missing data. What we don't want are ambiguous answers that are complex, and if there's very few answers or missing data. So again, it depends on your research question versus your clinical question. Next slide, please. So how do we decide? It comes down to the medical ethics of autonomy, beneficence, non-maleficence, and justice. And you know, we need to ask, what information does the patient want, and what information does the clinician want, and what information does the researcher want? And then what do we do with the information? Where do we store it? And how do we store it? Who do we give it access to? Because there's, especially with next generation sequencing, there is a risk of a real risk to the patient, because there's so much information, and this could potentially be used to bias against them, say for insurances and stuff like that. And we also want to know, can we do something else with it? Can it be used in further research, which I think is an ethical way of using a scarce resource. But we have to be very careful that we don't misuse it, because there's such a potential for harming the patient, and we don't want to do that. And then we need to do what will have the most benefit, firstly to the patient, then to society, then to anybody else. What will cause the least harm, and we have to always be careful about that. And we also need to be cognizant of the cost. So what will be the least wasteful for everyone? Next slide, please. And then coming back to these ethical questions will have an impact on how we approach this diagnostic dilemma here. Next slide, please. Just going briefly into the ethics of genetic diagnosis, we will need informed consent. The patient will need to know what the scope, the risks, and the implications of genetic testing. And I've put Sanger sequencing versus next generation sequencing because they are actually very different. So Sanger sequencing, the scope is narrower, so the risks are less. And the implications of genetic testing are quite simple and straightforward. Whereas next generation sequencing, the scope is huge, and there are lots of unforeseen, or there's lots of potential for unforeseen risks. So we might identify a gene that causes, variant that causes premature Alzheimer's, and that could be devastating to the family. Next slide, please. The other thing that is absolutely vital and is often overlooked is genetic counseling, and it's essential for interpreting the results from the patient's perspective. Often the genetic counselors, the guys that I've dealt with, they have such a different outlook or view of genetic testing, and it just gives another point of view to when we are diagnosing. And it's so important to have them there for the different viewpoints. And there are often things that we don't consider at all as clinicians and as researchers. So genetic counseling is absolutely vital for us and for the patient to understand, for the patient to understand the risks, because often they don't understand the risks at all. And there's also a potential for uncovering consanguinity or non-paternity. So these are some of the minefields that we have to cross over. So the point is that it's very complex, much more complex than we often give it credit for. It's a process. It's not once off. It is an ongoing process, and it takes weeks to months to do it properly. And I doubt that it ever fully stops, to be honest, but yeah. And I need to point out that there are often cascading effects for the family. There's lots of stigma. So we need to be very, very, very careful. And I've just put the Sanger sequencing, next generation sequencing there to point out the differences and, again, the massive differences in the amount of information that you get. Next slide, please. There's huge psychosocial impact. There's potential for anxiety. You know, if you diagnose somebody with enamel renal syndrome, one of the questions is going to be, can I pass it on to my children? What are the risks of me passing it on to my children? I mean, we all know as autosomal recessive disorder, the risks are very low, but not zero. And there's always a potential for it. I mentioned the stigma earlier, but there's also potential for altered family dynamics. And there can be a lot of blame when it comes to genetic disorders. Next slide, please. I touched on privacy and confidentiality. Genetic information must be protected. There's a huge scope for abuse. It hasn't, as far as I know, it hasn't really manifest yet in society. I know in the early 2000s that there was a lot of worry that medical aids would abuse it or big pharma would abuse it. I personally haven't seen it, but I also might well be ignorant. So we need to be aware of this risk and protect it and be actively protecting it. Next slide, please. Oh, and that's the end of my talk, and I want to thank everybody for their time, and I look forward to any questions. Thank you so much.
Thank you, Wesley, for the presentation. We're going to take questions at this stage. You can type your questions in the chat. There's one question already. Prof. Baker will take us through the question. Otherwise, you can raise your hand and they will unmute you. Thank you, Prof. Baker. There's a question in the chat.
Yes, thank you, Prof. The first question is to Dr. Mpungose. It's an interesting case, but have you considered generalized odontodysplasia?
Yeah, thank you for that question. And yeah, it's a possibility. But and definitely with the ghost appearance like of the teeth, multiple unerupted teeth, but the exact picture of also odontodysplasia isn't really fitting there. I know there are open apices on some of the teeth, but you know, when looking at the periapicals that we could get, you know, it wasn't necessarily enlarged pulps, and there were calcifications, which meant we needed to look, or we need to look a bit deeper. So it may very well be that it could turn out to be that. However, I think Dr. Talikan covered it in one of his slides where he says, what information are we looking for? Because I think it's important that we don't, you know, when we have a hammer, every problem is a nail. So, and I think here we need more information before we decide on any intervention, because the exact clinical picture of what we may think it is not really it. So it would not hurt to just investigate a bit deeper so that we can use the approach it correctly and have the correct intervention. I hope I've answered.
There's another question on the chat. Is it to Dr. Mpongose as well?
Yes.
The second question is from Maboesha Makunyane. And the question is, when do the clinical renal manifestation typically occur? The second one, same person. What is the dental treatment plan for the patient that present with this?
I'm sure the renal question we can pass to Wesley.
We can pass. I'll try to attempt it in the sense just based on the literature I've read on this. The renal manifestations will probably typically appear at a later stage, and what we'll often see first is the patient who presents to you with a dental complaint. So it's important to maybe just keep at the back of your mind that there is this possibility, because the renal issues may appear much later in life, but this would present itself in the primary dentition as well as in the permanent dentition, and that's what generally will bring the patient first. So it's important for us to know that that is there, and so that we can refer appropriately so that it's managed correctly. Truth be told, on the second one, in terms of treatment plan, do we have another 5 hours? It's a bit complex in the sense that we always, you know, we don't want to lose unnecessary structures in the oral cavity. However, you know, these teeth are not going to erupt. There's possibly no way to get them to ever erupt. They are non-functional. It's now as to how do we best get the patient functional. I'll tell you, with my first case I saw that was diagnosed with ERS, was a young, just newly qualified specialist then. You know, I went right up to the try-in stage, not try-in, to the jaw registration stage, only to realize there's no space. So the treatment thereafter was to remove everything and try and create space for any prosthesis. But, you know, there are others who would argue against that. You know, is the removal of everything the most appropriate way to go? And I don't know what else could we have done. So, but these are the ethical dilemmas and the clinical challenges that we face. And this is something that's so rare that we do need to find ways on how to appropriately manage it.
Thank you for that response. Any further questions? The renal question, Wesley, do you want to attempt the renal question? At what stage of life does it occur?
So I think it's going to depend on the on the type of mutation and the severity of it. The literature that I've looked at, it seems to be in the mid to late teens, but I'm not 100% certain, because a lot of these the manifestations, so recurrent urinary tract infection, microscopic hematuria, non-specific abdominal pain, are often going to be missed. So I think, you know, and then the teeth are generally more clinically visible. So I think that renal disease often gets missed. And even when the diagnosis is there, 50% of the patients don't have renal disease. So I'm not 100% certain, but I don't think that that's the primary clinical presentation. It would be very rare for end-stage renal disease, say, and to present with enamel renal syndrome. I was also maybe going to ask Dr. Mpungose, the patients with enamel renal disease, do they have softer mandible maxilla bone, or is it normal in your experience?
Look, I'm not going to pretend to have a lot of experience with it, but we, in the cases that we did manage, we didn't find that there was an issue with the mandible and maxillary bone. But that may be something that we overlooked, and you know, it's not something we had investigated. So at the moment, I would say no, and also there isn't much that speaks to the quality of bone in the literature as well.
Yeah, no, I agree. The literature says nothing about bone, but I really think that there must be some sort of decrease in bone quality or density because of the loss of calcium and phosphate in the kidneys. So it's something that I think we should look at. I mean, it might be a dead end, but yeah. Thanks.
Thanks, Wesley. Do you think the amenorrhea and the scoliosis in the first patient are related to this, or is it just by chance?
I don't think the amenorrhea is related, but the scoliosis maybe. It's if there is bone disease, secondary bone disease from this, like a secondary hyperparathyroidism or something, then scoliosis is possible. But there are also lots and lots of different causes for scoliosis as well. But in a young person, it's unusual. So I would look into that at least and see. It may not be enamel renal syndrome. It may be another syndrome with amelogenesis imperfecta, but we won't know immediately.
Okay, there's one more question in the chat, Prof. Baker.
We have a question from Lesehu Masha again. This is to Dr. Tulliken. If no renal abnormalities are detected and gene sequencing is not suggestive of ERS, then how do you plan to proceed with the treatment plan?
So I would then refer that to Dr. Mpungose, because if there's no renal disease and there's no genetic disease, then then there's no role for nephrology. But I'm pretty, the images that he showed, I think, are pretty syndromic. So I think we'll find probably some sort of syndrome, and then we can go from there. With enamel renal syndrome, the treatment is only symptomatic at the moment. So, the renal treatment is quite limited.
You have a comment? Okay, go ahead.
Yeah, thanks. Look, mine is not really on specifically the treatment plan, because that would really vary, because then it just becomes an intraoral problem. But what I found very interesting in again one of the slides from Wesley was that when it came to the genetic mapping and the counseling thereafter, it really hit me that we work in silos. These patients presented, one looking about I can't chew, the other saying I want to smile. And I think these are really basic things for us as dentists. But lo and behold, there's a genetic and a familial issue, and as I said, there's a lot of stigma, and and it really hit me that at times we need to stop thinking about just drilling and filling, and really we preach about managing patients comprehensively, and I really wonder if at times we do that. We just saw a local problem that we wanted to manage, but thank goodness something said, let's look deeper, because there definitely is something else that's happening beyond drill, fill, and bill. Yeah.
Thank you. We do not have other questions. Wesley, I'm going to put you on the spot. One more question. Okay, right. Prof. Mapasek, are you going to read the question, or he wants to speak?
Thanks, Prof.
Have you unmuted him?
Hi, can you hear me, Prof?
Yes,
Hello.
we can hear you.
Okay, thanks. So thanks for the very interesting talk. And I hear from both the speakers about the distress that families undergo, and lifespan and so on. Having said that, I think Dr. Mpungose has alluded to the function. We've just heard about the possible issues with bone metabolism. We also know that with the multiple unerupted teeth, and with the concept of partial extraction therapy, is there any chance of improving function by using dental implants in these cases without removing any of the teeth? Dr. Mpungose, maybe, and then with the bone metabolism, is there going to be a possibility that there might not be integration and maybe a foreign body reaction? Thank you.
Thanks, Vicky. Sandile?
Yeah, thanks for that question, Vicky. Very loaded, but let me attempt and say this. I hear you about partial extraction. We still sit with one problem, even post partial extraction. There's no space, because if you think about it, you've got these teeth embedded in bone, multiple teeth unerupted. You've got this gingival fibromatosis. There's really no space for any prosthesis. So, and for you to create any space, as we would call it, you're going to have to just level everything, you know. Partial or serial extractions here and there will only gain you space where you've removed and placed, but then there's nothing else in between all of that, because there isn't space for a prosthesis that would survive the forces and function. So that's one of the more complex problems. And definitely you're right, with then bone metabolism, we're then not sure what can be done. Will the implants survive or not? You know, how long will they survive? Will they also integrate? So one's not really sure. I can tell you with these cases, there isn't a lot that's written in terms of how they are prosthetically managed post-diagnosis. So it remains a challenge.
Thank you. If there are no other, one more. We're running over. It's quite interesting though, so let's take a bit more time. Thanks. Go ahead, Prof.
We have a question from Dora Mugambi. She mentions an excellent point about treating the patient holistically and thinking multidisciplinary. The question is, how often has this inculcated in curriculum, let alone practice?
It's been thrown at me. I think we could do better. We now only trying to introduce interprofessional education. It's been like 3 years that's in the curriculum. But as I said, it's going to take a while for people to accept that we cannot be lone rangers and we need multidisciplinary teams. So quite challenging, but an important point that we all have to note as we manage these patients, because it becomes complex and therefore cannot be managed by one specialty. So we note your concern, Dora, and we are addressing it in the curriculum, but as I said, we could do better. And in fact, I said to Prof. Baker in a note I wrote on that submission that we have an opportunity with this center that you're planning to introduce multidisciplinary, interprofessional, interdisciplinary teaching. So thanks for that question, Dora. And I think we've all noted the difficulty of making a diagnosis in these cases, because they present with a variety of symptoms that may be serious and non-serious. And actually, for the clinician, it might be quite difficult to connect the dots. So the dentists have to be kinder to themselves. However, we need to have and these kinds of discussions, hopefully, will raise awareness around thinking about rare diseases when we see our patients, because the presentation is often multi-system, can start in the pediatric age, can start in adulthood. So we just have to keep it at the back of our minds as we see these patients. So I'm going to allow Wesley to sketch the next steps for these 2 cases. And for me, what it's going to cost to get to some diagnosis. That is, what are the costs for the tests that we are proposing, Wesley, as you summarize what's going to happen to these 2 patients now?
Thanks, Prof. Yeah. So what I would like to what I'd like to see is, I mean, I would like to see them and evaluate them clinically. I would offer them counseling and offer them the testing, but I would focus on doing whole exome sequencing. I think that's where we're going to get more bang for our buck, just because I don't think we can hang a nail on a specific diagnosis here. I don't want to be held up to a specific cost, but the previous whole exome sequencing I've done has been about between 5,000 and 6,000 rand per person, which is not terribly much. But if you do a lot of them, it adds up very quickly. But yeah, so we could do whole exome sequencing, let's say for under 10,000 Rand per person. And then we could have a proper diagnosis, and we could counsel the patients appropriately. Does that answer your question, Prof?
Yes, it does. And I have another one. Where do we keep the data? Have we now created a database where we're going to put all this information? Because for me, that would be important. It's part of what you're trying to do in developing a center of excellence.
So we've got REDCap up and running. I can do a data storage on there. Otherwise, we could just do plain data storage. We could chat to the IT guys and have a secure storage on one of the SMU servers. So I think that should be easy enough
and protected enough.
Yes, yeah. So REDCap is off the. It's accessible only. Our REDCap is only accessible in South Africa at the moment. We can open it up to other countries, but it's not searchable on Google. It's password protected. So, okay. Yeah, it's
all right. I'm happy.
Be reasonable.
It's been quite interesting. And interesting that the cases actually are from SMU. So I think we're off to a good start. And we look forward to feedback, Dr. Mpongose and Wesley, on the outcomes of these patients. Colleagues, as we said, the series of webinars will continue so that we can begin discussing all these matters. I want to take this opportunity to thank Prof. Seheri, Prof. Baker, and Ray 360 for organizing this meeting. But most importantly, thank Dr. Mpongose and Wesley for preparing these cases. We really have had, I've enjoyed the talks, and I look forward to the outcomes of the gene sequencing. May I take this opportunity to thank everybody who has joined. All the questions you have asked have left us with food for thought. As we shut down the meeting now, have a good evening, everyone, and thanks for attending. Thank you, Mfundo, for the technical support. Good night, everyone, and goodbye.